Our next presentation is by Dr. Bharti Kashyap. She'll be giving tips on EOG.
So first of all, good morning everyone, and I am thankful to All India Ophthalmological Society and our Chief Instructor, Dr. Kashyap sir, for giving us this opportunity. So I will be talking about EOG, and this time I have added few more clinical examples in my presentation. Hope it will be beneficial to all. So there are tips on electrooculogram. Who is credited with the first description of EOG? The EOG is described and named by Elvin Marg in 1951. The clinical applications were described first by Geoffrey Arden. EOG is the test to measure standing potential of the eye, approximately 5 millivolt, indirectly transepithelial potential that exists between the cornea and the Bruch's membrane at the back of the eye. The normal light peak requires normal functioning photoreceptors in contact with the normal functioning RPE. It tests RPE and outer retina. Actually, before the clinical examples, I am giving some anatomy and physiology behind this and the principle behind this EOG, so that it will be easy to understand. During the 15 minutes period of dark adaptation, there is a fall in the recorded standing potential, typically reaching a minimum at 10 minutes, and this is referred as the dark trough. Following light onset, there is an increase in the transepithelial potential of the RP, producing light rise of the EOG. The light rise is ultimately the result in intracellular free calcium, which is released from the endoplasmic reticulum, regulated by an interaction between endoplasmic bestrophin and L-type calcium channels associated with the basolateral membrane. The intracellular calcium gates the opening of the basolateral calcium-dependent chloride channel, and increased chloride conductance depolarizes the basolateral membrane, which increases the transepithelial potential, recorded at increase in the standing potential of the eye. The prerequisites are dilated pupil, full extraocular muscle motility, refraction correction is not needed, pre-test 20 minutes room temperature, light adaptation, good visual acuity, and impedance should be less than 5 kilo ohm. The instructions are: head position should be stable, eye movement only in horizontal direction, head should not move, never anticipate and move prior, increase illumination in case of non-dilating pupil, avoid any bright light procedure before EOG. The Ganchfield dome is the stimulator. The fixation target is 2 LED lights, 15-degree left and right of the central light. And the it is bright during light adaptation and minimal brightness in the dark. The pupil should be dilated before testing, and after suitable skin preparation, the recording electrode should be placed close to the canthi of the each eye. For the dark phase, total darkness should be maintained for 15 minutes except for the dim fixation light. And for the light phase, a Ganchfield background light of 100 photopic candela per square meter should be turned on. Continue the recording for 10 seconds out of every minute in each phase. Active and reference. The position of electrodes near medial canthi is very important. It should not touch. There should be separation, else there will be a contamination which can go up to 40%, and it should be less than 15% contamination. You can see here on the picture there is a black ground electrode, blue reference electrode, and red active electrode. In our hospital we use this, and the patient has to move his eyes to LED with single sweep with head fixed. Second, recorded 10 to 15 seconds per minute, 40-50 seconds rest. Measure 15 minutes in dark and 15 minutes in the light. Arden ratio. Now I am discussing the clinical part, how it is applied clinically. So Arden ratio is very important. It is light peak by dark trough. It is normally 2.1. Less than 1.7 is abnormal, and usually it is seen in the Best disease. The parameter which should be included in EOG report is a light peak and dark trough ratio, dark trough amplitude in microvolt, implicit time from the start of the light phase to the light peak. Also mention type of adapting light source, pupil size. Note any difficulties encountered during testing which may affect the confidence in the results, such as inconsistent eye movements, etc. What is the reliable EOG? The reliable EOG is presence of square and regularly placed waveforms. If it is not proper, that means patient is either not fixing properly or electrode is moving. Light and dark values taken in respective adaptation period, typically 12 minutes for dark trough and 25 to 26 minutes for light peak. Background illumination, again you have to check 100 candela. Normal light rise in EOG requires a normal RPE and good photoreceptor function. As the light rise depends on the photoreceptor function also, patients with abnormal rod function will have a corresponding reduction in the light rise, thus mirroring the extent of the rod photoreceptor damage also. So, if ERG is absolutely negative, then EOG would be absolutely negative too. Some photoreceptor action is must to have an EOG reading, so we recommend always to do ERG and EOG together and never in singular form. A bit in case of good rod function in ERG, a reduction in the light rise in EOG is suggestive of abnormality located in RPE, that is Best disease. Now few clinical tips. The most common diagnostic use of EOG is to confirm vitelliform macular dystrophy. Patients with Best disease and some patients with adult vitelliform dystrophy have normal ERG and abnormal EOG. You can see here the EOG is reduced. Now, the electrophysiology in bestrophin gene mutated dystrophies, in Best disease, which is autosomal dominant, and other kind of bestrophin gene mutated dystrophies, EOG is reduced and ERG is severely reduced in only Advilk. Advilk is autosomal dominant vitreoretinokeratopathy. Usually ERG is normal, and in autosomal recessive bestrophinopathy, it is moderately reduced also. I will show you clinical examples. EOG is abnormal irrespective of the stage of the Best vitelliform disease. You can see here in one case it is a vitelliform disease and another case fundus is looking normal. But in both the cases the EOG is showing abnormal. Here, if a child with suspected Best disease is, suppose you cannot perform EOG, then you test both the parents because one carrier parent will surely exhibit abnormal EOG. This is one case of Best disease, autosomal dominant, 11-year-old male, blood vision, BCVA6/9. You can see the fundus picture, you can see the vitelliform disease, and you can see in autofluorescence. But if you cannot see vitelliform lesion, fundus looks normal, then also this autofluorescence, fundus autofluorescence helps, and this region in autofluorescence will be there in case of there is abnormal looking fundus. Absence of abnormal looking fundus. Here in OCT you can see the SRF, subretinal fluid, and vitelliform deposits. So here you don't have to give intravitreal injections, but if CNVM develops, then in that case you have to give intravitreal injection. Here you can see ERG is normal and EOG is reduced. The light peak in the bright field is reduced. This is another case, 10-year-old man, male, born out of consanguineous marriage, blood vision, BCVA 6/18 partial, hypermetropic diffraction, and narrow angle. You can see by fundus photograph, there is a lipofuscin deposits, and in fundus fluorescein angiography, there is it is not very clear. The diagnosis is not very clear. But once you go to the fundus autofluorescence affair, you will see subretinal fluorescein deposits predominantly outside the macula. And here it is not diagnostic, here it is diagnostic. And here you see that OCT. In OCT, it is the accumulation of fluid within and beneath the neurosensory retina. Here you see ERG. This is autosomal recessive bestrophinopathy, and you can see here ERG is abnormal, here EOG is totally extinguished because it is inherited autosomal recessive way. So in this case both ERG and EOG reduced. In this case this is autosomal dominant Best disease, ERG is normal, EOG is diminished. This is the autosomal recessive ARB. In 2017, the newly devised International Society for Clinical Electrophysiology ISF standards for clinical EOG induced fast oscillation of EOG. This is actually not very much in practice, but we should know that in near future it will be more popular. The advantage of FO EOG is test time is shorter, making it easier for patients to be tested. Slow oscillation of the EOG are recorded during 15 minutes of dark adaptation, following by 15 minutes. On the other hand, FO EOG has the advantage of greater compliance because the total inspection time is 15 minutes. The fast oscillations are different from typical EOG, which is dependent on calcium-gated chloride channel. These are sinusoidal in form, different from the typical square form of EOG. The alteration takes place in 1 minute interval. and mechanism is also very different. This happens at the apex of the RPE, near the retina, not at the base. The fall in subretinal potassium reduces the movement of chloride ions into the RPE. This is not calcium dependent. The resulting hyperpolarization is responsible for the light trough. There it was a light peak. Here it is a light trough followed by dark peak. There it was a dark trough during recovery. Here apex is having different potential. It has a role in distinguishing whether CSC is central serous retinopathy is acute or chronic, evaluating RPE function. In chronic CSC, decreasing RPE function is confirmed by decrease in amplitude of light trough of FO EOG. FO parameters can be used as indicators for detecting the severity of macular function disturbance and predicting the visual outcome for this in CR view also. So thank you so much. So I discussed in detail anatomy, physiology, and the applied and the clinical.
Thank you, Dr. Bharti. Quite elaborate and newer aspect of the EOG also. Thank you very much.